It all changed today.
Sorry I didn't stop at your booth today. I didn't realize.
That's fine. That's fine. We're there tomorrow too.
Yeah, I'm not.
Oh no.
I leave at 7 in the morning tomorrow.
Oh, where are you going?
Back to LA.
Oh, okay.
Thank you for being here. Oh, you're welcome.
But we do a lot of genetic stuff, so I should talk to you.
Oh, great.
We have an inherited CMT clinic.
Wonderful.
Are we ready to go? Are we live? Aloha, Honolulu, and aloha to all of you tuning in on this webcast on the internet around the country and around the world. We're very happy to have you here. I say around the world because that's not actually an exaggeration. There are times when we have people from all over the globe tuning into these Ask the Experts. Not every community where there's ALS have the benefit of having incredible expertise, and so our chapter, along with the other work that we do, committed to creating access to these wonderful professionals through the internet and through the technology that's available to us. And so we're very happy to have everyone here and very happy to have all of you here in the room with us and all of you watching on your computers and smart TVs and mobile devices and whatever. As long as you're not driving, we're good with that. And it is totally okay to laugh at all of my jokes. I want to just get that out. I will not be offended if you laugh. My name is Fred Fisher. I'm the President and CEO of the ALS Association's Golden West chapter. And we actually started doing these webcasts in Hawaii a few years ago as part of our initial effort to do outreach to the ALS community living in Hawaii and bring the expertise of the medical community that really comes from all over, and tonight's panel is no different. We have a terrific panel of experts to present to you, and it's fulfilling one of our core mission priorities, which is to create education and outreach and awareness so that everyone understands what ALS is and how to live well with it. And that's our fundamental objective. Everything we do as an organization supports the search for an effective treatment and cure, and we're very grateful to have all of you as part of that. Tonight, we're fortunate to have a local neurologist with us who is responsible within his practice, the Neurology Associates. Neurology Associates sees Neurology Associates sees more people living with ALS than anyone else in the state of Hawaii, and so we're very grateful to have such a terrific expert joining us tonight as our moderator for this evening. So without further ado, it's my pleasure to welcome Dr. Brandon Hirota.
Thank you very much for that very nice introduction, Fred. Good evening, everybody. Thank you very much for joining us here today. My name is Brandon Hirota. I'm a private practicing neurologist here in Honolulu. I work primarily out of Kuakini, but also I'm seeing patients at a number of the other hospitals here in town as well. So you're probably wondering, at a big specialty talk like this, what is a little private practicing neurologist like me doing here? Well, I have a particular interest in neuromuscular disorders. I did my residency training at UCLA and then stayed on for an extra year studying neuromuscular diseases there as well for my fellowship. And I've continued to hold an interest in neuromuscular diseases since returning here. I'll admit it's not a big part of my practice, but it's a part that I really enjoy, and I enjoy the patients that I meet going through this. So one of the diseases that I come across is amyotrophic lateral sclerosis, which all of you are here to hear about today. And I'll be very honest, prior to this first year, I honestly didn't know very much about the ALS Association and what it had to offer. I knew the name, I knew that it was associated with ALS, but beyond that, I hadn't had a whole lot of interaction with them. Then, all of a sudden, over the past couple of months or so, I started to notice my patients mentioning, oh, this Taryn Davis came to see me, and it's been helping us kind of work through all the different problems that have been coming up. I'm sitting there thinking to myself, I don't know who Taryn Davis is, but that's good. Any extra help that I can get with taking care of my patients, I'm more than open to have that. So eventually, I had the pleasure of meeting Taryn, Fred, Kahala in person, and being able to sit down with them and see what exactly their ideas, thoughts, and ideals were regarding the care and fight against ALS. So, as you know, ALS is a very complex disorder. It's complex biologically, clinically, socially, and that really takes a certain type of care model to treat it effectively. Now, what I see as a private practicing physician here is probably a little bit different from what our expert panel here will discuss here tonight, but it's an ideal that I think that we're going to be working forward towards. So, in my experience, there are a number of professionals here that I think are very good and quite skilled at managing the aspects of ALS. It's just a question that sometimes it's a little bit fragmented. So I know a number of our patients are on the neighbor islands. Even coming from the west side, coming across the H1, I know what kind of a nightmare that can be traffic-wise. It's an almost whole day affair just to come into town to see one specialist, only to have them tell you, okay, you need to go and see this specialist, this therapist, and you're going to have to make that trip back and forth again. So it can be very, very frustrating. But what this is all leading up to is the development of a multidisciplinary clinic. And what exactly is that? I'm going to let Dr. Lewis really discuss the fine details regarding that, but the bottom line is it's a one-stop shop. It's all of your specialists and your therapists in one visit, same day, taking a look and focusing on the problems that you have. Now, this isn't only just a convenient thing, but it's also a very effective means of providing care for our patients. So it's sort of like when you get a whole bunch of people all in one room, they synergize together. And although we have everybody right now seeing our patients separately, it's a little bit different than having them all in the same room at the same time, being able to focus on you and your care. So I look forward to that as we move forward. And what else I think that this offers and affords to us, we're very isolated here in the middle of the Pacific. And a number of times I've had my patients ask me, well, what can we do? How else can we be involved? What's going on treatment-wise, research-wise? What's available out there? And logistically, it's very difficult to be involved in any of that. Just financially, being able to make the trip to the mainland, and oftentimes with research, it requires multiple trips there or very frequent visits. And ideally, looking down the line, what having a specialized state-of-the-art clinic here would offer is perhaps more opportunities to participate in research and be on that cutting edge. And I hope that our other distinguished guests here today can also describe that a little bit more. But enough of me talking and rambling. I think that we're all very excited to hear about our distinguished panel here and what they have to share with us. We're very lucky to have the American Academy of Neuromuscular Medicine and Electrodiagnostic Medicine here having their annual conference this week. So without further ado, I'd like to introduce our first speaker, Dr. Richard Lewis. He's a professor of neurology at Cedars Sinai Medical Center in Los Angeles, California. There, he's director of the EMG laboratory and also the co-director of the neuromuscular clinic program. He's a member of the Cedars Sinai ALS Clinic, and he's involved in a number of ongoing clinical trials. He's been involved in ALS care and investigation for over 35 years. He's directed a number of ALS centers in Connecticut, Virginia, and Michigan. For 19 years prior to his move to California in 2013, he was Associate Chair of Neurology at Wayne State University and Director of the Hiller ALS Clinic and Research Center. Dr. Lewis?
Thank you very much. I got this one right. There we go. So I was asked to talk about the multidisciplinary clinic, and I'll do a little bit of that, but I'm not sure that's exactly what you want or need to hear tonight. And I think what you really want to hear is about care issues related to problems that you and your loved ones have, and how we deal with it and what may we be able to help you with in the future. So I appreciate everyone coming tonight, and it's a delight to be here. So this is our ALS multidisciplinary clinic. And I haven't counted them all, but it looks to be about 15 or 16 different people and disciplines involved in our clinic. And I don't want you to come away saying that you can't get good care without a multidisciplinary clinic. It's pretty clear that it does help, and it's great to have it. But what's most important is to recognize, and I think you do already recognize, that ALS causes a lot of different problems. And it causes issues that you need to really be able to deal with. And you need to have people like Brandon to be able to help you work this through and know who it is who's going to give you the best care of the different problems you have. So our clinic really starts, and I don't even know if she's here, well, our case manager, that's from our House of Case Managers is at every one of our clinics and is very helpful. And for you here, as you work, ALSA can be extremely helpful to you to terms of figuring out how you can deal with some of your problems. And so if you're struggling knowing what to do, ALSA can work with you, and they certainly can get in touch with us to help out. The most important person is not even on this slide. Well, this is the most important person. But the other person who's most important is our clinic coordinator, who solves everyone's problems. She herds the cattle, she makes sure that she answers the phone, she listens to all the different problems you have and makes sure that they get handled. So in our clinic, Tammy Kendrers does that job, and she does it extremely well. And we have nurses, we have research coordinators, we have a pulmonologist who comes to the clinic, we have a respiratory therapist who works with the non-invasive ventilations. If our patients come in saying that BiPAP mask doesn't feel good and I don't like it, he works with them in the clinic to change masks or change how they use the mask. So all those things are quite helpful. And we have occupational therapists and speech therapists, physical therapists. We have wheelchair people. It's quite a clinic. We also have, I'm not even sure that's on here, we have a neuropsychologist and psychologist who works with us. So it's a wonderful clinic. I have to say, I've developed clinics around the country, and this one is very special, and I'm proud to be part of it. So this one, they're going to do all that, and I don't think we need to do that. It's cute, but I don't think we need that. By the way, I'm happy to be interrupted because I don't necessarily think you want to hear me totally, and if you have questions, please feel free to interrupt me. So the fact is multidisciplinary clinics are a good thing. The American Academy of Neurology has recognized that. There have been studies that have shown that getting care in multidisciplinary clinics is very helpful. So one of the goals that I have, and I think everyone in our clinic would have, is that we know that this is a very difficult disease to live with and to care for. And we know that we don't have really very effective treatments. I wouldn't even say, we can leave out we don't have effective treatments at all. And so what is the goal of the clinic? And that is so that people can live their life as fully as possible within the realms of what your disease allows. So if my patient comes to me and they're struggling, they have foot drop or something, and they say, I want to climb Mount Everest, I might have to say that may not be a good goal. But if they said, I want to travel, or I want to do this, and the answer is, yes, we can help you do that. And that's what we want to accomplish, is for you to live life as fully as you can within what the disease allows you to do. And sometimes you think the disease won't allow you to do that, but maybe with our help, we can figure out ways to get around that. So the other aspects of this is that we also are very aware that this disease affects not just the person who has the disease, but the people around them, families. And so we work very closely with families, and sometimes separately with caregivers and spouses and children, to work with them to kind of deal with some of the issues that they have. And sometimes we become a bit of marriage counselors a little bit about taking care of each other and everyone being mindful of the needs of the other person. So one of the things I wanted to bring up is this goal of living life as fully as possible. There's a bit of an obstacle that occurs with that, and that is sometimes to do those things requires you to accept the fact that you need help and that you need an aid. And whether it's a brace or a cane or a walker or a wheelchair, but if you want to go somewhere and walking is not going to be able to do it without the walker, then my recommendation would be, let's use the walker. And frequently what I hear from patients is, I don't want it. I'd rather not do it than have it. And the question is, what's that all about? What is the driving force behind that reluctance to use something that would help you do what you want to do? And I don't have all the answers, and there's a lot of things that go on with that. But what I have recognized over my multitude of years of doing this is that one of the things that's probably the most difficult for people to deal with is the loss of independence and to be dependent on someone else. And most of us have cared for others in our life in many different ways, whether it's your spouse or your children. And to be cared for is a very, very difficult thing for people to accept, embrace. Caregivers, spouses are usually very happy and to do whatever they can, but it's very hard to be on the receiving end of that sometimes. And the other part of it is that for many people, they don't want to be reminded, and I understand this, that the disease progresses. And so every time someone says, well, why don't you use a cane now? That's kind of like lost a battle, that this is the disease progressing. And I understand that, and I think it's important that we talk about it. But in the end, what will allow you to do the things that you want to do, sometimes you have to accept those things to help you so that you can live life fully. So multidisciplinary approach, as Brandon mentioned, is basically one-stop shopping. So the patients come to our clinic, and we scatter them throughout the day. We have a full day that we devote to the ALS clinic, and people spend 3 hours, sometimes 4 hours. Usually it's 3 hours. And one of the things we try to do is not wear you out. It's a tiring day. And so one of the things we try to do is prioritize what are the major needs today, and focus on those. And the rest of it is, if you have the energy and you want to keep, stay longer, then we go ahead with the other things. For some people, it's speech therapy and the diet and the nutritionist. Sometimes it's the respiratory part. Sometimes it's physical therapy. Sometimes it's talking to me or a counselor about issues that are upsetting you, issues about making decisions about what you're going to do in the future. So all of these things take time and energy, both psychic and physical. So we try to work all those things out. The other thing that's very clear from our clinic visits, almost every patient wants to spend a lot of time talking about what's new in research. What are you doing? What's new on the horizon? What's the possibilities that might be able to help me or at least someone else in the future with this disease? And so we spend a lot of time talking about that. Sometimes Dr. Balo, my colleague and the director of the clinic, does a lot, and he does a lot of ALS research. He's in the laboratory a lot. And we have a research coordinator who's superb, who goes in and talks about virtually any clinical trial going on in the world about what's going on there. So we're happy to talk about that. So this is what we do. We see the nurses come in, every patient comes in and they get a breathing test, so we see how strong their breathing is, and we follow that over time. We follow a functional rating scale called the ALS Functional Rating Scale and monitor that as we go along. And we get weights on everyone. We have, Cedars Sinai is very fancy. We have fancy examining chairs that weigh you at the same time. And then usually Dr. Balo or I will come to the room and talk to the patient, figure out what the issues are that day, and then coordinate the care. So what does the physician do? We talk about different medicines, and the only, as you know, treatment that's been approved for ALS is riluzole, and it's been around for 20 years. And the studies show that it helped some. It's not a home run. The Mets would not have won the game yesterday if they used riluzole. I grew up in New York, a mile from Shea Stadium, so I am slightly sad. I've moved since then. I've picked up enough teams. So we do recommend riluzole, but if someone says I don't like it, I don't want it, I'm not terribly upset for them, but we do recommend whatever we can do to help, we try to help. So some of these clinical issues, I don't know how much time we have, but just to go over a few things. The biggest issues that I see in clinic are respiratory and swallowing. And as you know, the respiratory problems in ALS have to do with the strength of the muscles for breathing. And so the ability to take a deep breath in and blow out the carbon dioxide is a big issue. And it turns out carbon dioxide is actually the bigger issue in ALS than oxygen. So people with monitor breathing frequently in the hospital with those oxygen saturation things on your finger, they stay normal in ALS until breathing is very, very severely compromised. It's the carbon dioxide, blowing out the carbon dioxide, that's a problem that makes people sleepy and cranky and otherwise. So when people start breathing goes low enough, then we would frequently say you should use non-invasive ventilation, or what's called the BiPAP. Those who have sleep apnea, like myself, use CPAP, which is continuous positive airway pressure. But in ALS, it's BiPAP, so it helps you breathe in, helps you breathe out. And it's very effective, and probably the most effective thing that we have in ALS. It prolongs people's lives on the average about a year. So it's a good thing to use, and people use it at night, or they use it during the day, or they use it both. And as, unfortunately, the disease as it progresses, people need to use it more and more. It will not work forever. And so at some point, one has to make a decision about whether one wants to have a tracheostomy and be on full-time ventilatory support. And that's a big issue, a bigger issue than I can discuss in detail this evening, but it's something that you, your doctors, and you as a family need to talk about very carefully and seriously. It's become a little easier to manage ventilators at home, but it still remains quite a, it takes a lot of care to take care of someone on the ventilator, and not everyone wants it, so I think it's something that needs to be carefully discussed. You may have heard about diaphragmatic pacing, and I'm happy to discuss that with you. We're very involved in that, and it's become quite controversial based on some studies in Europe that's come out in the last couple months. Swallowing, probably, and the issues of saliva probably take up as much of my time as anything else in care of ALS. It's a real problem for patients. It annoys them. It frustrates them. And I say them, you who may be having that problem right now. And we work very hard to try to deal with that. So we have a speech and swallowing person who works with us. We have a nutritionist. We don't like people losing weight with this disease. We don't want you fat, but we don't want you losing weight. And we recommend people eat a good, balanced diet, and if, at times with nutritional support. The PEG is the feeding tube. It stands for percutaneous endoscopic gastric tube. And we sometimes recommend it very early in the disease, or at least reasonably early, before they necessarily need to use it a lot, but allows people to eat, to get their nutritional needs met, not just by eating, but can be actually supplemented at night. It makes someone not have to, if you're taking an hour or an hour and a half or 2 hours to eat, you can change that to eating socially with your family for 20 minutes or a half hour, and then getting the rest of the nutrition while you're watching TV. So it's a very helpful, and some people say, I don't want it, and if that's the case, we talk about it, and if they're clear that they don't want it, we work with them. But most people who get it, I say the very vast majority who have the gastrostomy tube, are appreciative that they have it, because it helps them with medications. It helps, it's a comfort to some extent to know that if I need something, I can get it in. I don't have to necessarily swallow it when I'm struggling. So we do that a lot. This is a big word for saliva, but dealing with saliva, it's not that you're making more saliva with this disease, it's the fact that you can't swallow it. We all swallow our saliva without thinking about it all the time. But when you have the disease, it's not so easy. And the more problems you have swallowing, the more problems you're going to have with saliva. And there are medications that help. So I mentioned some of them here. They're all based on a chemical atropine. And there are atropine drops, which are used for eye doctors use. But you can drop a drop on your tongue and do it. The problem with a lot of these things is that it does reduce the amount of saliva, but it dries it up too. And sometimes that's more of a problem than having loose, liquidy saliva, is to have thick, stringy saliva. So I apologize if it's not the most pleasant talk, but it is the nature of the beast, so to speak. So one of the things that we do a lot of is using Botox, and you can get a 2-for-1 if you want wrinkles taken out, as well as your saliva. But Botox to the salivary glands can be very effective, and for the most part, doesn't cause the dryness that the medications do. Yes?
Is that the same as the myoblock?
Myoblock is a form of Botox, yeah.
There's not really a difference.
It's a different type of Botox. I'm not a Botox aficionado, but
So they're just type A and type B. Myoblock probably is used a bit more for ALS because it burns less, or so patients say.
so, but it continues to be a problem. You can do it every 3 months or so, and it is helpful. It's not a perfect solution, but it's, and I think we're still looking for the best way to do this, but right now it's usually a combination of these medicines, and you have to find the right dosing. Not too much, not too little, that kind of thing. So we have speech, and we work on speech issues very early with our patients, and there are good apps for your iPad and your iPhone that work well. There are some what's called boogie boards where you write and then erase it. So there are lots of different ways to do it, and then it can be more complicated with computerized speech devices. And it's helpful to think about those things and learn how to use some of them early. Some people do some voice banking that can be utilized as well. There's a ton of other symptoms. So I'll tell you, just pick one, because I don't want to go over too much, because it takes up too much time, and I'm probably out of time now anyway, aren't I?
We're a minute.
Huh?
Still good. 5 minutes.
5 minutes.
Yes.
Okay. So I'm New York. I can speak very fast. The emotional lability one. It's the third one down there. This one, where people sometimes have inappropriate laughter or crying, and sometimes will cry more than they're feeling sad, or laugh when they mean to cry, or cry when they mean to laugh, and that is what's called pseudobulbar affect, and has to do with the central nervous system motor control system for affect. And there is a very good medicine that works for that. So the Nuedexta, is anyone on that here? It's a medicine that basically takes the cough suppressant in your cold tablets, dextromethorphan, and drives it to the brain by giving you a little bit of quinidine, which is a heart medicine, and it's very effective to control that symptom. So we use that quite a bit. It's quite helpful. And we do deal with depression. I frequently tell my patients, if you're not crying a little bit, then you're probably avoiding thinking about your disease, which is not necessarily a bad thing, but it's not. But a little bit of tears with your family is an appropriate response to a very terrible disease. If you're crying all the time and so sad that you can't live life to the fullest that's allowed, then we feel we should intervene. And families usually tell us when that occurs. And there are good antidepressants, and sometimes talk therapy a little bit. You don't want to spend tons of time doing it. My wife's a psychoanalyst. I wouldn't suggest going 5 days a week to see her, but although she does a great job, but it can be very helpful. Pain. ALS as a disease doesn't cause pain, but not being able to move an arm can freeze your shoulder, and you'll have shoulder pain. Not moving your legs can cause muscles tightness and cramps. So I suspect many of you have some degree of pain somewhere in this, and we need to deal with it. And we try to do whatever we can to work with you to kind of deal with the pain. We are usually partially successful. We're not always successful, and sometimes it's a combination of physical therapy and different things to kind of work on those things. So not all patients have access to multidisciplinary clinics, and I applaud you here trying to develop this. It's not an easy task. It's not so simple to get all these people together, to get all the powers that be allow their employees to do this for a day, and it's not necessarily a money maker for hospitals and health systems, but it's a wonderful thing. It's good for patients, and if you don't have a multidisciplinary clinic, recognize that there are people out there that can help you. And we are happy to work with anyone here in terms of giving advice. If you want to give us a condo on the beach, we can get our people to come over every once in a while to assist you. I saw one that I really liked the other day. And ALSA can be extremely helpful in helping you deal with some of these problems, whether the expertise is here to deal with it, but we can certainly help your doctors and your staff and you to work on these things. On that note, I think, thank you.
We have a couple of minutes before we go on to the next talk. We can open it up to questions from the audience.
Yes.
Do you, in your clinic, do you see people who are in skilled nursing facilities as well as veterans?
We do see both. Now, the VA hospital has their own ALS team and clinic to some extent, but they frequently come to us as well. Sometimes it's for research issues, sometimes it's just because our team can give them a little bit more than they get at the VA. But we work with the VA because they get a lot of their benefits through the VA. So we do have a few patients from the VA. Skilled nursing facilities, we work with them, and sometimes the families will, or the facility will bring the patients over to us. So they come sometimes, every once in a while in a stretcher, usually it's, wheelchair. By the way, the wheelchair issue, there's chairs that are manual chairs that someone pushes, and then there are power chairs. The power chairs, I used to call them the Cadillacs, but since I'm in LA, I now call them Bentleys and Lamborghinis. They're expensive. So Medicare usually allows you to buy one. So we frequently say buy the Bentley through Medicare and either there are some loaners and getting the manual chair, which is considerably cheaper, figure out a different way to get those. The problem with power chairs is you have to have a van to bring them around, so they're good in the house, not as easy to get you from one place to another unless you have a van. But you can certainly get ramps to get them down and out of the house, but you have to deal with those issues too. Yes. Yes.
Question from the internet. When will there be a multidisciplinary clinic in Hawaii? If there isn't one, where should we go?
So Dr. Hirota is hoping to develop one here relatively soon.
Relatively soon. I don't think that I can give you an exact date for when there will be a multidisciplinary clinic here in Hawaii. I can say that I am in talks, and I've been working together with the ALS Association to try to formalize that and get that started here.
So one of the things I will tell you also, until that happens, we at Cedars, and I suspect other clinics in the California area see patients from Hawaii. So we've had quite a few patients from Hawaii come to our multidisciplinary clinic. They usually come once, occasionally they come twice, but because they've established care and we understand some of their needs, they contact us by phone and email. We talk to their doctors so that they don't necessarily have to keep coming back. We're working on some telemedicine approaches so that we can, I've Skyped with one patient and it was partially successful, but we're working on trying to develop that so the patients who don't have access to multidisciplinary clinics can at least have access to some of us so we can know their problems, and then sometimes if it's a physical therapy, speech therapy, we can have our speech therapist on the telemedicine, our side of the telemedicine. Yes.
Is it easy to diagnose from clinical dementia? Does it have to
So depending on your definition of frontotemporal dementia and how sensitive your testing is, the statistics are as much as 60 to 70% of patients with ALS will have some degree of frontotemporal dementia. And so I need to define that for you. So the dementia that we all think about mostly is Alzheimer's disease. And Alzheimer's disease is primarily, it's not just, but its memory is a problem. In frontotemporal dementia, the memory issues are much less. It's more of sometimes judgment can be altered a bit, sometimes behavior. So some families will say, my spouse who has ALS is not behaving the way he would normally have behaved. He's not the same guy or she's not the same woman that I knew 3 years ago. I'm answering questions here. So it's an issue that comes up. Sometimes it can be quite severe. Sometimes it can be more severe than the motor neuron disease at certain stages of the disease. So when it's pretty obvious, it's not hard to diagnose. When it's subtle, then you have to go through some more testing and things. So we have a neuropsychologist at our clinic who actually works with us to do this. There are some screening forms that some of the multidisciplinary clinics use. So you can figure it out. It sometimes gets mixed up with the pseudobulbar affect, and that can kind of confuse things, but they're separate issues. So on that note, I'm not answering any more. You have one more? Yes.
Can you comment on Marinol?
Yes, so the question is, can I comment on Marinol? Or medical marijuana would be an alternative issue here. So my comment is, I have patients who use it and find it helpful. I'm on the internet. I can't say any more than that. But the fact is, people use it and it's quite helpful. I just had a call from a friend of mine who has MS, and for him, it's been extremely helpful. Some people find it helps some of their spasticity. And so, from my standpoint, if you're struggling, it may be an appropriate thing to consider.
Thank you. Thank you very much again, Dr. Lewis. So moving on, next on the schedule, we have Dr. Stacy Rudnicki. She is currently a professor of neurology at University of Arkansas for Medical Sciences. She is the Catherine and Thomas May Chair for ALS and the director of the ALS clinic there. She has been the local investigator for a number of clinical trials in ALS, and most recently has explored the relationship between early weight loss in ALS patients and its impact on survival. In December, she will be joining Cytokinetics and will be involved in their clinical trial on tirasemtiv. Dr. Rudnicki.
I'm going to go slideless tonight. I'm really throwing caution to the winds. So thank you for asking me to speak tonight. A number of years ago, the first ALSA meeting in DC that I went to, I met a couple from Hawaii, and I was really impressed that they had come to Washington, D.C. From Hawaii. They were a delightful couple, and so I remember them fondly. So I'm really glad that I'm able to come across the other way and speak to you tonight. So I was asked to talk about where we stand with clinical trials, and I thought it would be useful first just to talk a little bit about trials that are done in ALS. And of course, there are drug trials, and the diaphragmatic pacing trial, stem cell trials. And unfortunately, you don't get to participate in those in Hawaii because you don't have the clinic yet that leads to you getting asked to participate in trials. But there are some trials that you can still be involved in, and a project that I know Steve Gibson will talk to you about that's looking at risk factors for ALS in some ways. But people are also interested in getting blood from people. And for example, Northwestern has for many years collected blood samples from patients with principally familial ALS. And you can do that remotely. You do not have to travel to Chicago to participate in a trial like that. And they love it if you have an extended family and they can collect blood samples from those people too. But that's something to consider, is reaching out to some of these clinics that are looking at large samples of genetic material. And I think, if we understand why people get the genetic form of the disease, we would learn more about why people get sporadic disease as well. So I would suggest to you to think about participating in a trial in that sense. You can do that. I've had, in Arkansas, we've sent samples of genetic material, just blood, just a simple blood draw, and sent it off. And so that's a remote way of being able to participate in a trial. So I would encourage you to think about doing that. I'm going to give you a little bit of background about the phases that phase 1, phase 2, phase 3 trials, because I think that's important for people to understand, in part because it gives you an idea when you hear people talking about a trial, how close is that to maybe getting really an answer and moving forward into being a drug that gets approved. And so phase 1 trials are the really small trials. They frequently have 20 or fewer patients in them. It's the very first trial that's being done with the drug in humans, and it's really geared towards safety and try to figure out what dose is tolerated, so tolerability and safety. So in general, you're not looking at outcomes. Now, an exception to that is going to be the stem cell trial I'm going to talk to you about in a little bit. But in general, frequently these are done in healthy controls first, and then patients with the disease. But they're really small, short duration trials that aren't looking at efficacy as a general rule. Phase 2 trials are looking at, still the focus is on safety and collecting data on safety as well as tolerability, frequently pharmacokinetics, how people metabolize the drug. And they're in the ALS world, 8 to 12 weeks is not unusual in terms of the time somebody would be involved in a phase 2 trial. And a lot of times those trials have 100 ALS patients in them. That wouldn't be unusual, maybe 200. And then phase 3 trials are really starting to look at whether or not it works. So in phase 2, they'll follow things that tell you whether or not there is a potential to move forward, seeing if there is an impact on, for example, vital capacity or muscle strength. They're not going to look at survival in a phase 2 trial because it's too short to look at survival. But they'll pick some parameters that they'll follow, and they'll see whether or not there's a promise that it looks as if it may be beneficial. And then the phase 3 trial is really the trial where, while you continue to collect safety data, you also are collecting information as to whether or not it's benefiting the patient. And in ALS, we tend to follow all sorts of things when we follow patients in a phase 3 trial. We will frequently look at the ALS functional rating scale that was mentioned as something we do at each visit. Vital capacities, something called a SNP, which is another respiratory parameter that we follow. And of course, in the longer phase 3 trials, you're also going to look at survival. So phase 3 trials frequently last as long as a year because you want to get that survival data. And the phase 3 trials will have anywhere from several hundred patients to as many as nearly 1,000 patients. So that's just to give you a little background so that when I talk about different trials and tell you what they are in terms of a phase, you have that groundwork to think about. So I'm going to talk a bit first about stem cell, and I know I agree that you get asked all the time when patients come and visit what's on the horizon in terms of research. And if I had to pick one topic I get asked the most about, it would be stem cell therapy. And I should just say that all the trials now are phase 1 or phase 2. So these are very early, really doing that preliminary work that's seeing whether or not something is safe or not. And stem cells can be obtained in a lot of different ways. You can obtain stem cells from the bone marrow. And indeed, some of you may have had friends over the years who had stem cell therapy for certain kinds of cancers, because it's been around. Bone marrow stem cell harvesting has been around a long time to treat in certain kinds of malignancies. But in this circumstance, we're taking patient's own stem cells. That's called an autologous stem cell because it's from yourself. And they're manipulated in a variety of ways and then can be injected back. And we'll talk a little bit about where people have been injecting them. You can also obtain stem cells from adipose tissue. And indeed, the Mayo Clinic is currently using adipose tissue stem cells in a trial. You can obtain them from umbilical cord blood. So I know in Arkansas we have an umbilical cord blood bank, which means that moms, when they deliver, can donate the umbilical cord blood for future studies. So this is doesn't pose any ethical dilemmas for people. It's babies that are being born. The OB draws the cord blood, and it has this. These cells have the ability to become other cells. That's the whole idea. You want them to become other types of cells. And then there are fetal stem cells that are from aborted fetuses. And so those are the sources that have been used in a variety of studies that have been done. I think the one that probably has attracted the most attention is the one done at Emory, sponsored by Neurostem, and that's the project where they injected the cells directly into the spinal cord, and so it required a surgical procedure, so it's, needless to say, a big deal. And indeed, they insisted patients move to Atlanta to participate in that trial. And they did, in some patients, they did it just at one level, and in some patients, they did it at 2 levels. And that was an 18-person trial, so that was a very small trial that got a lot of attention. In part because, as they reported, they had one patient who transiently seemed to improve, and so that was very exciting. And they're now in their second study, which is a phase 2 study, but it too is a study of just 18 patients. So we're still talking very small numbers of patients. They used fetal cells in their study, and if you're getting cells from somebody other than yourself, you also need to be immunosuppressed. You need to take medicine to prevent your body from rejecting the cells that you're getting. I mentioned before that the Mayo Clinic is doing another stem cell trial that I think is enrolling about 40 patients. It's only being done at the Mayo Clinic, and they're injecting the cells into the spinal fluid. And then finally, a study that's being done at several sites and sponsored by a company called Brainstorm, in which they're injecting it into the spinal fluid and into muscle. And so there are a number of different trials out there, but they're small in number and all phase 1 or phase 2. So we're really just, and Cedar is very interested in stem cell, and you might want to add.
Our trial will be starting in probably the spring, so we're getting close. I can talk about it later.
So I think it is an exciting area, but I do always try to put a little bit of touch of reality because it is such a new area, and we're very early on exploring how they may be of benefit for patients with ALS. going to next talk a bit about investigational drug studies. And I'm not going to do every study out there. I picked some of the bigger ones to talk about tonight. The stem cell ones I picked because I know I always get asked that in my own clinic. So a couple of the bigger studies that are going on now, one is Ibutolast, which the Carolinas Medical Center is doing. So it's a single center study. They plan on enrolling about 160 patients. And this is a drug that is felt to impact glial activation. And nobody knows why people get ALS. We know a lot of things go wrong. We know ultimately motor neurons die, but we really don't understand the triggering event. But one of the theories behind one of the things that go wrong is glial activation. And so this is a drug that potentially may impact that. And it's a phase 2 study, it's a phase 2 trial, so it's kind of in that in-between stage of development. You heard before that I'm going to be joining Cytokinetics in early December, and we'll be working on the tirasemtiv trial. This is a multi-center, multinational trial that is a phase 3 trial. So the phase 3 trial is going to enroll over 400 patients. And it is, some sites are up and running, and there are some sites in California. That would be the closest for you. Another trial that's ongoing is ezogabine, which is a seizure drug. It's a medicine that's on the market currently for seizures. It is the theory in using this drug is that it suppresses hyperexcitability in motor neurons. So one of the theories, again, as to why motor neurons are lost is that you have kind of an excess excitation going on. They're overly excited and they basically burn out. And so this drug is felt to potentially be able to suppress that hyperexcitable state and lead to motor neuron survival. And so their target in looking at this drug isn't looking at things like functional rating scale scores. It's actually looking at response to transcranial magnetic stimulation. So there you can stimulate the brain through the skull with basically a magnet, and you record potentials. And so in this trial, they're going to be looking at whether or not you suppress the excitability as measured by doing the recording from this stimulation. So it's kind of an unusual study in that sense. And I'll make a final comment about diaphragmatic pacing, and Rich may want to add to this because I was not a trial site for this study. But the diaphragmatic pacing story is kind of murky in many ways. So in the United States, you can get approved for a device if you demonstrate that it's safe, but it doesn't necessarily, you don't necessarily have to demonstrate that it's effective. And so when diaphragmatic pacing became available in the ALS world, that's how it basically got approved. It was effective in treating patients with spinal cord injuries and helping them come off of a ventilator. And so it was kind of a natural segue to try it in ALS patients. And the studies were done not as a randomized, double-blind, placebo-controlled, and that means that people are randomized means it really is random. You know, person A gets drug A and person B gets drug B, but it's random. It's pulling something out of the hat. Double-blind means that I don't know what you're getting as the physician, and you don't know what you're getting as the patient. And so, and placebo-controlled means some people don't get anything, or they get something that's inactive. And so instead of doing that sort of trial, it was a study that was done comparing it to historical controls. And there's lots of issues with looking at historical controls, not the least of which in in the ALS world is things change over time. And hands down, Richard Lewis mentioned helping people with non-invasive ventilation, and that's been a huge change over time. And even the machines have gotten better over time. So what people were using 5 years ago aren't the same as what people are using now. So historical controls have some issues with them. And so when they used the historical controls, they found it didn't reach the, it seemed to have some benefits. And so they went to the FDA, and like I said, the FDA proved it in this sort of funny way that allowed it to be done because it was viewed as safe, but the efficacy was still in question. So a number of different trials then ensued, at least 2 in Europe, 1 in Great Britain, 1 in France, and then 1 in the United States. And you may have heard that this summer the Great Britain study decided to terminate early because patients who had been randomized to receive the pacing actually fared worse than those who received standard medical care. And that led the U.S. study, I believe, to stop enrolling patients but continue to follow the patients who had been enrolled. Is that correct?
Yeah, that's correct. I mean, I think there's a bit of an overreaction, but you can talk about it later.
But I do think that story maybe helps us realize why it's important to do those trials, that you want to know an answer. And one of the, when I mentioned the study that's being done with the medicine that's already on the market for seizures, I'm sure there are patients out there who would like to take that drug. But I've been in ALS world long enough to know that things that preliminarily look beneficial turn out not to be beneficial. And it's so important to collect the information, the data, to get the answer so that patients are taking things that make sense and aren't taking things that may prove harmful. So I'll also endorse the concept of trial participation in any way you can. And I'd be happy to take questions. Yes.
Do you know anything about the research that's being done at Johns Hopkins by Philip Wong and Jonathan Ling on TDP-43 protein?
So TDP-43 protein is, somebody asked before about the Alzheimer's, the FTD and ALS overlap. And TDP-43 is one of those proteins that is seen in both of those entities. I don't know specifically what sort of research they're doing with it. Do you know specifically what they're doing?
I know they came out recently with, I think the New York Times even had an article about it. So there's some interesting things in cell models and others that are encouraging. I don't know the details. I don't recall the details to talk about it. But, I mean, it's an important issue that we need to work on. But so whether it's going to be for a certain group of patients, there are patients who have genetic disorders in TDP-43, or whether it's going to be good for all patients, we don't know. And we're really not close to getting it to patients yet.
Yes.
Question from the internet again. Why are there so few active clinical trials for ALS?
Yeah, I mean, it is, yes. The question was why there are so few clinical trials for ALS. And, this is something, I've been in ALS for over 20 years, and it definitely waxes and wanes over time. And there are different, I think it's partly how motivated companies are in pursuing it. How I think having a negative trial like the dexpramipexole trial, which was a huge trial by ALS standards, close to 1,000 patients that proved to be ineffective, was so disappointing, and I also think it frightens drug companies a bit from developing. that's my take on that. I'd be interested in hearing what the two of you think.
Well, I would just say that there are a number of trials. The problem is there have been incredibly few, if any, positive trials. And until we understand the mechanism of the disease better, we're going to be struggling trying to get good clinical trials to control or cure the disease. There are clinical trials for symptoms. The tirasemtiv trial, which we're going to be participating in, is hopefully going to help muscle function, but it's not going to cure the disease. So there are things out there that, and I'm very excited about that trial. I think it's going to help people. I'm hoping it will, but it's not going to cure the disease.
Well, I actually think that there's an exciting horizon for people with ALS and drug trials. I've also been in this field for almost 20 years, 18 years, and when I first came to the association, the FDA had a different sort of culture. They were looking primarily to look at efficacy for survival. And that's changed. In fact, what's really exciting about the new trial that Stacy mentioned with tirasemtiv is that they no longer will look just at breathing. They will actually look, the FDA, at muscle strength. And so the more we can have various sort of ideas on how we can test drugs for people with ALS, it's going to be a new horizon. I mean, there's not a person with ALS I've ever met who doesn't want a few more years. And the FDA, when we first started to look at this, we're looking at, oh gosh, unless it's a game changer, we're not going to approve it. And the culture has changed. We're also working with the FDA to be able to establish a guidance document to give companies a roadmap to be able to say, hey, what has worked for things with ALS, what hasn't worked, so new companies can get involved. We're also updating the clinical trials and guidelines, so that will be easier for clinicians to get in. This FDA guidance project that the ALS Association has undertaken really consists of the entire ALS community, over 100 people. There's 13 different companies, a number of patients, a number of caregivers, and a number of great clinicians like Dr. Rudnicki. So we're really hopeful for that. We had a great meeting with the FDA last month, and in fact, they're so excited that they believe they're starting their process now too. So we're not going to have to wait like other diseases an extra year to look at that. We've got a meeting with them at the end of the year. And so we're very, very hopeful that that culture has changed and that more companies will come in this space to develop a therapy.
They were so enthusiastic, they moved up the deadline so that we had tomorrow is the deadline for the preliminary documents, and I'll be on a conference call tomorrow at 11 to discuss that. But I do think that's a huge thing to give to the FDA, kind of a standard amount of information so that it's there, it's readily available for them and for companies who might not have originally wanted to explore the ALS world. I've always thought that companies partly are interested in ALS because it's a neurodegenerative disease. And some of the drugs, for example, Riluzole, which has been around for a while now, after Riluzole came out for ALS, they also looked at it in dementia and Parkinson's disease. Now, it didn't work in either of those, but I think that is partly, it's a good thing to be in a field where it's considered potentially drugs might cross over into other diseases, because the reality is there are a lot more people out there with Alzheimer's and Parkinson's disease, and if a company thinks, gee, maybe if we can make an impact in ALS, then we can move into these other diseases. That's, I think, actually a good thing for the ALS community to be kind of thought of as it might spread into other avenues of use. So,
Well, and there are large companies who are involved in this guidance process who don't have anything in the pipeline yet. So it's so encouraging for them to say, we want to participate because this can really open up so many avenues for us that someday we will invest in that.
yes.
You talked about the stem cell trials out of Emory. You mentioned that was fetal stem cells. Are they predominantly fetal stem cells? And if so or not, why?
So Emery's are fetal stem cells, but different projects use different sources for stem cells. And, it's not involved in any of these trials. I don't know why they choose one type over another. I know many of these are, cells that they try to manipulate. So, they'll try to manipulate them so that they make more neurotrophic factors. They will, I believe the Emery ones are stem cells, are fetal stem cells from spinal cord. So, they use different science behind choosing it. Where are your stem cells?
So we're using what's called iPS cells, and what you need to understand about stem cells, most people think about stem cells that we're going to try to make new motor neurons. And that's not what stem cell treatment's going to do. Because to make more new motor neurons, they have to connect, and they have to send that wire, that axon, down to the muscle. And that growth is an inch a month. It's very hard to do that. So our trial, which is very similar to the NeuroStem, the Emery trial, because we're going to be doing an injection in the spinal cord, we're providing a neurotrophic factor called GDNF, glial-derived neurotrophic factor. And the cells that we're making are called astroglia, which are supportive cells to the motor neurons. And they provide a lot of the nutrients and the growth factors to the motor neuron. So our goal is really not to make new motor neurons, but to make more healthy the ones that are partially sick that haven't died yet. And so that's what our goal is, and similar to the goal of what the NeuroStem is. So I just wanted you to be aware of that. The other trial I'll just mention quickly, are you wrapping up again? So just one other research, clinical, there's a certain number of genetic forms of ALS. And the most common one, the C9ORF72, which is about half of the known, there will be probably a clinical trial in the next year or two with what's called short interference RNA to affect that. And there's some very good reason to be quite hopeful about that trial. So.
Thank you very much. I think I'll hold on questions until the end. We'll move on to our next speaker, Mr. Steve Gibson. He's the Chief Mission Strategy and Public Policy Officer for the ALS Association. I could go through his entire bio, but that might be another talk here.
So cut you off.
I'm going to say that he's been an integral part in fighting for the ALS Association and making all the advancements that we've done so far. So without further ado, Mr. Gibson.
Thank you, and it's great to be here at an event with the Golden West chapter. As we mentioned, we're a national association, and the Golden West chapter is one of our 39 chapters. They really are one of the pioneers in advocacy, public policy. In fact, one of their board members had the foresight to actually make a large investment in the ALS associations for public policy, because he really believed of all what could happen when you get government behind a treatment, get government behind support for patients. And he enabled us to hire myself and have a good staff. And now the leadership continues with Fred Fisher and his team of Kahala and Taryn, and we're very fortunate here to have them leading the way on getting you the services that many people have throughout the country. It's also great to be here because we have one of our great advocates here, Elroy Chime. Would you please stand, Elroy, so everyone can see you? Some of the great things that I'm going to share briefly before I get to the registry, he has really been involved with. In fact, he came back many years. How many years, Elroy? Oh, 12? Okay. On getting the Hawaiian delegation to be co-sponsors to all of our initiatives, the ALS Registry, the Medicare waiver, and that's what it really takes. You know, I'm here as a cheerleader, but it's really great advocates like Elroy who make the trip to the local office here to get support, who make the trip to Washington to get support. So I encourage all of you to think about and get some tips from Elroy, because he really is a wonderful advocate and has continued after he lost his dear lovely wife. So thank you, Elroy. So one of the reasons why I'm here is to talk about the ALS Registry. Hawaii, unfortunately, is one of the under-enrolled states. It's out of the country, and so we need to spread the word to talk about the importance of this research project. It is the largest research project ever created for ALS in terms of dollars spent and in terms of patients involved in this. Now, as I travel around the country, you know, I always hear about these studies out there, and, you know, we know that there's a high incidence of soccer players in Milan who have ALS. We know there's a high incidence of football players who have ALS. We know that if you smoke, you're more likely to get ALS, and we've heard that if you drink, you're less likely to get ALS. Now, all those studies, though, were so small that we couldn't really say that those were really definite risk factors. And so what we're doing with this research project is to be able to get information from a large number of people to answer various questions and experience and exposures so that researchers can really look and help determine, are those things really risk factors? So the ALS Registry, for a little background, it's something that was really advocated and led by the ALS Association and their advocates. We heard from a number of researchers saying, you know, we need to get some understanding of these trends. There's all these small studies out there, but we can't really say this is a risk factor. And so we worked with members of Congress to introduce a bill in the Senate and then the House, and we were able to get appropriation dollars to support those things because, you know, a lot of our ideas we weren't sure, you know, could really be helpful here. And in fact, some of our success stories in advocacy enabled the registry to be successful. Back in 2000, we led a group of advocates to change the Medicare laws. We had a number of people with ALS who would pass before the 24-month waiting period had finished. And so we worked with Congress to pass a bill, and it's the only time the law has been amended, and it's amended for people with ALS, that they no longer have to wait 24 months to receive their Medicare. We also worked with the Veterans Administration after a number of studies showed that there's a twice likelihood if you fight for our country that you'll develop ALS, twofold incidence, to make people with ALS who served our country to be service connected. And it's a number of benefits that if you are a veteran and served your country for 90 days that you're entitled to. And I say that also to let people know that if you know of someone who fought for our country and served 90 days, that if they're no longer here, their spouse is eligible for this benefit. And you know, please work with the Golden West chapter to connect you with the VA, because as I travel around, a lot of folks have left the fight for this disease for a while and came back and didn't know in 2008 the VA made this change in law to enable those benefits to continue. So in 2008, the law was signed by President Bush, and in 2010 we were actually able to open the web portal for people to participate in. So, as I mentioned, this is a nationwide database, and it's run by CDC, actually ATSCR, the Agency for Toxic Substance and Disease Registry. So we really wanted to have some sort of system that was unbiased, because there had been attempts before for certain organizations to create it or certain pharmaceutical companies to create it, and there were a lot of challenges. You know, people didn't like the company or the organization, they wouldn't participate. So this is a national registry that is unbiased, run by our CDC. Some of the things I'll talk today about that the registry can help us with is to identify risk factors. That's something that many patients ask, why me? How did I contact this disease. It has a mechanism that will really help advance clinical trials, and it's something that I know is on the mind of many patients. And if you don't have a center, it's really hard to find those clinical trials. And I know we have an aspect to look at clinicaltrials.gov, but it's really, really confusing. There are aspects of the registry to improve the quality of life, asking questions every 6 months about your progression. And for the first time ever, there's one place on the registry website, no matter where you travel in the country, in that area. So right now, if you look on the ALS Association's website, you only find our clinics and our chapters and our centers. If you look at the Muscular Dystrophy Association website, you'll find theirs. Here's sort of a one-stop shopping. You'll find all the various, no matter where you travel in the U.S. And we also hope to get a better idea of how many people have this disease. So here is sort of my non-scientific pipeline I like to share, and it was a great job that Dr. Rudnicki did orally. But I say this because we look at public policy as we try to advocate for more research funding through this pipeline. Because having been in this field for a while, we worked with Congress way back in 2000 and the White House to double NIH's budget. And we weren't the only group to do this. We worked with many groups to do it. And we were very excited. And our expectations were that we will double the treatments and cures. And it didn't happen. And so we really kind of said, you know what is wrong in this pipeline? Clearly, it's not the fact that we have more money. We need to see how to spend those dollars. And so we looked at that pipeline and all the phases, and Dr. Rudnicki did a great job on explaining that the phase 1, which is the basic research right here, the phase 2 is a preclinical, and it goes from left to right. But I also share this on Capitol Hill because many of staffers don't understand this either. It's not just ALS that is very difficult to develop a treatment. I mean, this whole process, on average, takes over 15 years, and it costs $1 to $2 billion. Now, we used to say until this year $1 billion, but there's a new Rutgers study that shows it's actually $2 billion. But when you get that high up there, I'm not sure there's a big difference between $1 or $2 billion. But just to show you, it's a very expensive process. And so these are sort of all of our priorities that I won't talk about tonight, but you can see in phase 1, when it looks at the basic research and the risk factors, the registry can really help promote a therapy. You look to phase 2, we're finding that that's sort of the biggest risk for our research, that the compounds here go from 10,000 to 250 compounds. And so we really had to figure out how are we going to fund more research in that area? Because at the time, NIH was not funding research in that area. So we worked with the Department of Defense to create a translational research program to be able to focus on that next step of science. And in fact, that has alone enabled 4 different compounds to be targets for companies to pick up and push through that pipeline. And then finally, I want to share with you later that the registry also will help part at the end on locating clinical trials or getting people involved in clinical trials. So this pipeline is sort of the graphic that Dr. Rudnicki was talking about, and kind of just helps you to understand how tough it is to do that. So how does the registry work? Well, the registry is really composed of 2 aspects. On the your left, my right, up here is how it works with national databases, the government databases. And so those great things I told you about, we did, being able to waive the 24-month waiting period, being able to connect ALS with the VA, making it a certified disease, that really captures a great number of people in the government databases. And in fact, we determined that 80 to 85% of people with ALS have some form of government support. And on the left-hand side is the portal that if you're not part of those government programs, the only way you can be part of that registry is to enter through that portal that opened up in 2010. I want to point out, though, that this registry is all voluntary. Even if we've captured some of your preliminary data on the left-hand side, it's de-identified. So if you really want to participate, you as a person have to decide to do that. And I say that because we had a sort of a pilot project in Massachusetts of a state registry that had mandatory reporting. And a number of patients were very upset about that aspect because they wanted to kind of determine their own timetable on when they told their family, when they told their employers, when they told friends. So we're encouraging people to get more involved with this registry, but it is all voluntary. So if you're, both of these databases come together, and they basically can verify if you're a part of that by your last 5 numbers of your social security number that you need to put in the web portal, as well as what the databases have. And ultimately, it goes into one database. And just to let you know, part of the validation questions are for the portal is you have to have an ALS diagnosis. It can't be not sure, maybe. You have to have an ALS diagnosis. And I know that's sometimes tough because there are some diseases that mimic ALS, PLS, Kennedy disease, et cetera, that can't be part of this registry. And that was what Congress wanted, just because of the challenges of really creating a registry. Hopefully in the future, there'll be other ways to expand this registry, but right now it's only for ALS, and it's only for people who are living today. All registries actually start at one point in time and go forward, so it's really hard to add people after they've passed. The other thing is we want this registry to be very objective. And you'll see shortly some of these questions it asks that as we travel around and when patients ask us to help them enroll, we go through the questions, and no matter how long you've known somebody, it's amazing what they're willing to share with their loved ones or their friends about how much they exercise, how much they drank, and how much they smoked. So those sort of things are really personal, and that's why they want to make sure that the person's actually doing it themselves, so it can be very objective and actually true. So once you enroll in the registry, and we want everyone to enroll in the registry, because even if you are part of the national databases, just knowing the fact you have ALS is not enough. We need to understand where you lived, what you did in life as a lifestyle, what exposures you were, and none of those questions will be presented until you actually enroll in the registry. So don't get confused, because there's sometimes people will say, oh, I've already enrolled in Medicare, so I'm part of it. You're part of it, but it's not enough. We need to know the additional information. So as you enroll in the registry, this is sort of their, the CDC's site. We take no credit on making this confusing and cumbersome. It's a government website that they are actually working to be able to make it more user-friendly, and I think they just now advanced to be mobile-friendly. So it takes a little while for the government to kind of get up to the standards of everybody else on their smartphones, but it has improved, and it really, if you could only see the first year it came out, you would really see the advancement that it is right now. Now, once you're enrolled in the registry, you'll have a list of surveys. And all these surveys are various topics that are potential risk factors. Now, why they only say survey 1 through survey 18 is because we don't want to have any bias. Because, for example, if you are a non-smoker and you see survey 2 or 3 is smoking, I forget which one it is, you might have a tendency to say, oh, well, I don't smoke, so I'm not going to answer that. It's as important to know that you don't smoke as if you do smoke. And so we just listed by numbers for you to go to each one. And some are very short, some are a little bit longer than others. But these are the 18 that we have there. And as you can see, it's some of the most recent ones, talk about trauma. That's been something that's been in the news a lot with NFL players, and they're looking at see what impact that could have. Probably the one I'm most excited about is working with CDC on this open-ended question, because as I travel around, there are not many people I meet who don't have sort of their own opinion on how they came down with this disease. And I know we're not scientists in this room like some of the folks here. I think that information is just as important as what the scientists are looking at and talking about, because you don't know where that clue is going to come. One of the things when I first started, we thought ALS was one disease. Now we know that it's a spectrum of diseases, and what might help out you might not help out you. So I encourage people to answer that question with anything they might think of, whether it's an accident, whether it's decision to have to take another medication for another condition you might have. Put that in there so all of the top scientists and researchers can look at that, and that might become a question for later on. But those are the questions there. Now, some of them are it'll take a while for you to go back. I think when you get in there and they start asking you things on clinical research, et cetera, and physical education, et cetera, it is more confusing. So I'm told that my time is up, but I will, 5 minutes, okay. Your cards are better last night. So I won't go through on how to enroll this, but I will talk about two great features that are being added to the registry. One is a biorepository. And as Dr. Rudnicki said, there are biorepositories going on right now, but most of them, in fact, not all of them, I think, are not really national biorepositories. There are some cases where you can send in your samples, et cetera, but for the most part, these biorepositories are in cities you can expect. Boston, Baltimore for Hopkins, Los Angeles, all these very big cities. So the areas that are determined as remote or not near a center don't have that ability. So this will really kind of change that sort of discussion, because instead of you having to go necessarily to a biorepository center to give things, this biorepository will be set up so the medical professional either comes to you or you're able to send things in through your doctor or your clinic, et cetera. So this will be kicking off later this year, but more importantly, it'll be the first biorepository that'll be attached to your whole profile. So when a researcher looks at Sally M, they'll be able to see the tissue samples, the blood samples, the hair samples, and then say, oh, well, Sally M was in the military. Sally M lived near an iron smelter. These sort of things will finally give the researcher the full picture. And this is something that will be coming out later this year, and the research community is very, very excited about it. Something else I wanted to share briefly is that something that's changing the paradigm of clinical trials. I mentioned earlier that if you aren't near a center, if you don't go to a center, you really don't know much about clinical trials. Now, if you enroll in the registry and check the box saying you want to participate in this research notification tool, anytime you qualify for a trial, an email will be sent to you. You still have the option not to participate, but you'll be notified that you are eligible for this trial. And it's something that we just started doing a year or so ago. And at first it was very much small studies that various was working on. Now it's increased to larger companies getting involved. Biogen, I know Cytokinetics is talking about using the registry. So this tool is very, very exciting, and as it grows, it'll really make life easier for people who want to be involved in trials. So I'll end there. Is there any questions? Yes?
Question from the internet. Has the Ice Bucket Challenge helped with research?
Absolutely. The Ice Bucket Challenge has really helped with the entire disease picture of ALS. It has enabled us to be able to invest in partnerships that we never would have dreamed to do. We were able to really invest those first few months, our first $21 million in some incredible research projects throughout the U.S. It helped us with awareness, where people really kind of know that ALS is not MS or ALZ, it's ALS. It's helped a lot with awareness there. It's also helped with educating members of Congress. We usually do Dear Colleagues, which is letters to support some of our initiatives, and they usually get 40, 50. We had one Dear Colleague the summer it occurred that had 200 members of Congress sign on. So it's a great sort of tool for us for many advantages. I know that the three great patients that helped start it in New York, Florida, and Massachusetts want to continue it to happen every August until a cure, and we support that and hope you will too. Yes?
Question, and it's regarding clarification regarding your non-ALS, potential ALS,
Mhm.
true ALS patient. My husband was diagnosed with progressive bulbar palsy, and there was that confusion. Does that qualify you for being able to register at the ALS registry? And we delayed that registration for a while because he had a lost motor,
Mhm.
and I couldn't get a real clear answer that he would be a candidate to
Well-
on the registry, so we delayed it until he further progressed.
Does he have an ALS diagnosis now?
That's way.
Okay.
Okay. He finally got an ALS diagnosis. We went to the UCSW,
Mhm.
Multidisciplinary Clinic, and while he was originally diagnosed with progressive bulbar palsy, but when I pull up his report online, it says ALS, diagnosis ALS, and then I know that VA also won't give you any kind of VA disability with just progressive bulbar palsy. I think you have to use some motor or
Right.
to get an ALS diagnosis. So
Well, that was part of an algorithm I showed in that diagram that enables sort of CDC to review and look at all that, and they look at many things, and so they're the ones that would actually make the final decision on that. We ask people, though, to wait for that final diagnosis for then, but there's a number that in your packets, so you can always call CDC, and they can explain the algorithm better to you on at what point you should go forward into being able to enroll for that.
so they would correct not in delaying. the
Yeah, I mean,
registration. So you wouldn't register if you just had a diagnosis.
Yeah, I would actually I would wait, but I think it's always good to contact CDC and let them make the final decision, because they're the ones that review this and look at this with their research professionals. It's not us, it's done through them. And so your identity is protected and everything is safeguarded with them. Okay, okay, well, thank you very much.
Thank you very much. At this time, I think that I'll open up for questions to any of our panel experts. Yes.
Another question from the internet. What is the difference between a BiPAP and a CPAP?
So the question is, what is the difference between a BiPAP and CPAP?
So I mentioned it before, but maybe I wasn't clear, but so CPAP stands for continuous positive airway pressure. So when someone has sleep apnea, particularly obstructive sleep apnea, usually the pharyngeal, the palate is collapsing when you're asleep, so the continuous airway pressure opens up that palate and keeps it from collapsing. In ALS and other disorders of breathing where muscles are weak, you need help in breathing in and out. And the BiPAP is so when you take a deep breath in, or when you breathe in, it helps you with that, and when you breathe out, it helps you with that as well. So it's bidirectional, and it feeds off your own breath in terms of delivering the pressure. So one is continuously blowing air all the way in, it's continuous, and the other one goes in and out.
Any other questions from the audience? Yes?
So when many of us think about a treatment for ALS, we think about a drug first, and then sometimes we think about stem cell therapy. Can you talk a little more about gene therapy and some of the new technologies that are being developed?
So, I mean, I have been involved in some of this gene therapy approaches, and there's actually some very exciting work going on in gene therapy. So gene therapy is where you deliver a genetic product through, usually it's some kind of viral vector. So you take a virus, you make it so it's not infectious anymore, and you can put genetic material in that vector and deliver it to the person. And the question is, where do you deliver it? So sometimes gene therapy is done intramuscularly, sometimes it's done intravenously, sometimes it's done directly into spinal cords and things. So for instance, one form of motor neuron disease is called spinal muscular atrophy. And there's now some very exciting gene therapy approach to deal with that genetic disorder of motor neurons. Now that is meant to treat the specific genetic defect, just as this other treatment of blocking C9orf72 is a specific way of treating that cause of ALS. So gene therapy is another approach, And it may well be that what we're going to end up with is a combination of things. Maybe stem cells will be an approach. Maybe it's gene therapy and stem cells to work on trying to treat multiple aspects of the disease. And so part of the problem in any treatment, it depends. Something makes the motor system sick. We don't necessarily always know what it is. With genetic models, we know it's that genetic disorder that's the precipitant. But sometimes you can stop the disease at a later part, because starting from that disease, it makes the cell sick. There are protein degradation problems within the cell. Maybe you can stop those protein degradation systems. So a multifaceted approach may end up being what we need to do. So we're all kind of working different aspects, and that's why getting a big community of researchers, some looking at gene therapy, some looking at stem cell therapy, some looking at protein changes, some looking at genetic changes, eventually we're going to come together and come up with an approach.
Yes.
When we get our clinic here, we bring some of the trials into Hawaii.
You know, I actually identify with being in, somewhat isolated states. I mean, Arkansas is not high. I mean, I constantly hear, I've never been to that state when I tell people that's where I'm from. So, and I think you came for the first time last year, see? So I understand you do have to, and it's all about networking. So it is all about networking. So you need to come to the MND meeting. Are you coming?
I don't know when that is.
It's next month.
Oh my goodness.
It's in
December.
It's not quite.
Oh, no.
It's December, early December, because that is a great place to network. That really is. I mean, it's meeting people, and the first things you do are not clinical trials where you're giving drug. They're you can do a lot observing. That's you see enough patients, you start to recognize patterns, and you start to gather data based upon what you're seeing in your clinic.
December 11th through 13th.
Right. And
Thank you very much.
And it's in Orlando, so bring your kids. But the other part of it is, I think we would be excited to have a new region to find patients for clinical trials. So I think we would I personally be very excited about having a center. But it's not just having a multidisciplinary clinic, it also has to do with you have to have the right people knowing how to do the outcome measures. You need a research coordinator. So there's a lot of things that go into it. I'll bring up something else that I personally am interested in that may have some benefit, and that is we're going to get to the point where patient-reported outcome measures are going to be a significant factor in clinical trials. So I'm actually working on this with some developers where your iPhone or your Android phone will be able to deliver the clinical data that we need, and so you could be remote from a center and be participating in trial. That's a number of years away, but that's eventually what's going to happen. So I think there's reasons to kind of work on it in all different ways.
Yes.
How many, estimate in Hawaii alone, are ALS patients?
That's a very good question. Oh yes, I'm sorry. So the question is, how many patients here in Hawaii have a diagnosis of ALS? If you look at the epidemiology of this disease, and given the population here in Hawaii, maybe around 1.5 million patients, the number that you would expect is maybe around, I'd say, between 50 and 70 patients at any one given time. I will admit that I don't anywhere near that many number of patients in my clinic. I think that within my groups, we have a group of 4 neurologists. Probably we have between 10 and 20 patients within our practice, I would expect. But of course, there are a number of other specialists within the islands as well.
Thank
So 44 patients that are currently registered and following with the ALS Association here.
Any lifestyle medications that would also help with management of the patients?
I'm sorry, I
Oh,
did.
so the question is,
Lifestyle modifications that might help management of the.
So I think there are some things that can be helpful. So one of the trials that we did was to look at an exercise. So that is too much exercise bad? Is too little exercise bad? Is there a mama bear exercise where you just get the right amount of exercise? And so we looked at people with little exercise and a lot of exercise, and that result is hopefully coming out pretty soon because we've completed the trial. And I think there are aspects of things of, mindfulness and, and other things that I think are helpful psychologically, and how that benefits our bodies is hard to tell sometimes, but I personally think it's a good thing. But I'm not sure that there's a specific lifestyle change. Did you have one in mind, or?
I mean, I have certain clientele who managed to reverse, not specifically ALS, but I wonder if it could be applied to ALS. They reversed the progression of MS, and they also got into remission with certain types of cancer, which the medical profession wrote off completely. And I wonder if similar, such as Gibson therapy, the nutritional therapy, together with other things, I mean, as you said, mindfulness, like meditation, exercise, etc. So not necessarily any specific, but as a package, would it be a possibility that might manage the symptoms better? Or?
So there's no data to support that. Saying that, we don't know everything. So the way I respond to my patients, I'll see how Stacy wants to respond, is we've had a few patients who have done certain types of therapy that was very detrimental to them. They lost tons of weight and actually became sicker because of it. So the way I deal with that issue is I would like to talk about it. I'd like to know as much about it. And if it's not considered harmful, then I'm all for giving it a try. And it could be harmful in two ways. One, it could be harmful to your body because there's some risk involved. And the other part, it could be harmful to your wallet if it's very expensive. And so then there's that risk benefit in terms of, is this something you want? And maybe it's worth trying for a few months, but me not investing huge amounts of money into something that has unclear benefits. And that's something that people have to decide on.
Yeah, I endorse you have to be careful. This isn't specific to what you were talking about, but just thinking about, I had a young patient who had tried a lot of non-traditional things, and her husband said to me at one visit, it cost them a lot of money, $200,000 a year. And her husband said to me at one visit, of everything we've done, the thing that helped the most was going to the pool 3 times a week, which was something, which was doable, and they weren't paying extraordinary amounts of money for. And so I really do always encourage people to, not sell the farm. If we had a drug that fixed this disease, it wouldn't be a mystery. They wouldn't be selling it on the internet only. We would know about it. And so if they make promises that are too good to be true, they're too good to be true. And so as much as we all want to get drugs that are better than what we currently have, you also have to be realistic. So don't do things that are extremes. And I would also point out the ALS Untangled.
Yeah.
I don't know if any of you have ever looked at that, but it's a great resource where Rick Bedlack from Duke is kind of the person who spearheads that with help from various people. And they basically look at things that are out there, suggesting to be a benefit, and comes to some, present some evidence as to what they found when they looked into it, and whether or not any scientific sense that it makes sense, whether or not it would be harmful, whether or not it's just frivolous. And that is a wonderful resource, and that's readily available for free on the internet. So,
And they do a really good job on giving the whole picture of what the potential therapy is, if they have a charge, where those dollars go to, and they don't necessarily say it's a good or a bad thing. It's more just giving you more information for you to decide yourself. And it's alsuntangled.org.
Yes.
Have there been any trials that, for BiPAP and then non-invasive ventilation in comparing people going against each other?
Comparing what?
BiPAP and non-invasive ventilation, or either and comparing.
Well, non-invasive, BiPAP is non-invasive ventilation. So those terms are frequently used interchangeably. BiPAP is actually a brand name. So, and it's a brand that hardly, it's kind of been replaced. But there are a lot of different non-invasive machines out there. And now we're starting more and more to use ventilators non-invasively. And by that I mean ventilators that could be hooked up to a tracheostomy but are not being used in an invasive manner. And part of that trend has been related to the fact that you can higher pressures with them, because as people become more impaired breathing-wise, pressures need to be adjusted. Many of these newer machines self-adjust pressure, so you set a target volume, and they're smart. So if your target volume, which means how much volume of breath you're taking, if it falls, it increases the pressure to accommodate that. So they do all this kind of nice self-adjusting. They also have longer batteries. The older machines, you take them out of the wall and they're done. They don't work anymore. And so and more people now become dependent upon them 24 hours or nearly 24 hours. So the brands that can be used as ventilators by law have to have a longer backup. So they have to have usually at least an 8-hour backup, so that if your power goes off, that gives you enough time to get somewhere where there's power. So practical things like that. And people are doing some studies now looking at different types of machines to deliver non-invasive ventilation. So they're comparing these kind of self-adjusting ones to not, and those will be interesting to see. Over the years, I do know that our compliance has gone way up. When I first started to prescribe the older machines, it was tough to get people to use them at least 4 hours a night. That's the standard. 4 hours a night is what you need to use them at a minimum to get benefit. And they were noisy, and the masks were uncomfortable, and there was one size fits all, and we had different size faces, so that obviously doesn't work. And now the masks are soft, and they're the scuba kind of masks, and they make smaller ones or bigger ones, and ones that just go into the nose for people who are claustrophobic. So they've made huge changes in them. And so I think it would be interesting to do a study now to look at the survival benefits, because my guess is just because people can use them much more readily that the survival's even more than the earlier studies suggested.
Yes, I think we have time for one more question from the internet.
What would you say is the average life expectancy of a person with ALS? I've heard 2 to 5 from diagnosis, but also from first symptom. Which is it?
So the question is, what would be the average life expectancy for a patient with ALS from diagnosis and also from time of first symptom?
So, time to diagnosis is a bit variable. So that's it's harder. I actually think a better definition of survival is time from symptom onset, because almost all patients give you a month, and I've had some patients who can give me a day. when they notice their first symptom. Diagnosis is dependent upon referral patterns and wait times and getting to the doctor who recognizes what you have. So there's a lot of variability there. Now, I know from my own clinic, when we looked at this, patients on average took about 13 months from time of symptoms to time of diagnosis, and that's pretty typical if you look throughout the U.S. at least.
So the question was in part, how long, what's the life expectancy? And so there's an average, which is usually considered somewhere in the 3 to 5 year range. But we all have patients who live 20 years, and we unfortunately also have patients who have lived less than a year. So within that average, there is also a broad range of life expectancy. And everyone's different. And when people ask me to predict a specific, I can't do it. And I don't, and I think, again, the idea is to live life as fully as you can for as long as you can. That's what we all do.
Thank you. I apologize we're out of time for further questions, but I'll hand the mic over to Fred.
Thank you. Thank you. A round of applause. Thank you very much to our terrific panel and for Dr. Hirota moderating this session. I would be remiss if I didn't remind you of a couple of things. Our ability to bring you programs like this comes in part because of our vision to create a better world for people living with ALS and our commitment to having people living with ALS in Hawaii have access to the expertise, the information, and the support even though they're living in Hawaii. That would not be possible without many of the people in this room who have supported the Walk to Defeat ALS, our Hawaii Walk to Defeat ALS, our Campaign for Care and a Cure, and other fundraising activities that make it possible for us to give that back to the community. And we all know that from day one, from the very first time and our very first one of these Ask the Experts, our dream has been to provide all of those living in Hawaii, those on Oahu, those on neighbor islands, with a full array of services and support. And we are making real progress in that effort. Hawaii now has 2 full-time staff of the ALS Association that live here and that are dedicated here to serving the needs of people on every island throughout the state. And we, as you can see, are cultivating relationships with the neurologists here in Hawaii who are the experts in ALS and who are looking forward to being able to deliver this higher model of care. And none of this is possible without the support of the ALS community in Hawaii. And so I'm personally grateful to all of you for supporting our efforts, for being part of it, for letting us into your home, for making us part of your ohana, and for coming out, not just for the walk, but for these programs so that you can benefit by the content and then you can share the news of what all of us together are really building and making possible for the ALS community in Hawaii, the community that's living with it today, and those literally thousands of people in Hawaii that are at risk of being diagnosed with ALS at some point in the future. And we want to make sure that we're taking care of people today and that we're building the program that's going to support serving many, many more people until we have an effective treatment or cure. The challenge of an effective treatment for ALS will be that we have many, many, many more people to take care of. So we're doing the work early. We're setting it up early so that we're ready when we figure out how to slow or stop the progression, there will still be people who need us, and there will be more people than ever because people will be living with ALS for a very long time. And so what we're doing is not just about taking care of everyone today, which we are completely committed to. We want to be ready so that when there is a way to stop this disease, we have the capacity, we have the infrastructure, we have the resources, and we have the vision to take care of 2, 3, 4, 5, 10, 100 times more people. Because when you understand that the incidence of ALS is very similar to the incidence, say, of MS, but people with MS live a lot longer. And when people with ALS start living a lot longer, there's going to be many, many more of them. And you all in this room, all of you out on the internet supporting our efforts, you are all part of helping people today, but creating the program and the support that's going to be here to help people who are diagnosed in the future. If there was ever a time when it was more clear that we need to be doing all of our key mission priorities, that our public policy efforts that create the single largest source of research funding for ALS, that create the changes in laws to benefit the ALS community, that create the opportunity for new treatments to be explored, those therapeutic ideas have to have some place to go. And they go into clinics. And those clinics have to have people to try those ideas out on. And those people have to tell their story. And many of you are telling your story so that your legislators can understand the challenges you're facing and the need for ALS. And just today, we met with the entire Hawaii congressional delegation this morning for an hour and a half to talk to them about what people with ALS in Hawaii need and what we as the ALS Association are doing about it with your help and with their help. And that story results in more funding for research. It results in better laws to help people live with ALS, like just recently the Steve Gleason Act, which made augmentative communication devices coverable through Medicare. Those are tangible life improvements that are possible because you are lending your voice to our effort to change your life and make it better. And that all takes people. It takes families living with ALS, families participating in clinics, in public policy, and it's all powered by the Walk to Defeat ALS. And your support of that is making life much, much better today for people living with ALS in Hawaii, and will make life much, much better in the future for people with ALS. And personally, I can't thank you all enough for being part of that. I'm grateful to our panelists who took their time out from their conference to join us here tonight and share all of this information with you, and know that you know how to reach me, you know how to reach Taryn, you know how to reach Kahala. I can help you reach these panelists if you'd like. With any questions that you have, because the more you know, the better of an advocate you can be, the better story you can tell, and the quicker we will make progress against this disease. So with that, thank you very much for coming. Thank you everyone on the internet for tuning in, and we'll see you again soon.
When I first met you, I didn't know you were from Cedars.
Oh, that's okay.
Do you know Deborah Calick?
Deborah who?
Deborah Calick.
No.
She's the government relations person at Cedars.
No.
Yeah.
And your actual investment in Hawaii is huge. You know, we've been with you guys from the onset, from the first law. And I mean, we just don't earn enough money in Hawaii for all the resources that you bring to us, like as the experts, but the hiring of 2 people, we know that every year you threaten up to say, we're gonna up that goal, and it becomes like $100,000. You know, we never meet that goal, but I wanna thank the ALS Association because honestly, your commitment and
Well, thank you. We couldn't do it without you, and specifically you, Cookie. Thanks.
It's great meeting you.
Nice
Yeah.
meeting
Yeah.
all of you.
Great to
Good luck
meet
with that. I
you.
hope you
I hope
can
to keep in
develop your
touch with
clinic.
all of
Oh,
you.
yeah,
Thank you.
Yeah, yeah, so.
I actually created my clinic from
Yeah,
scratch.
yeah. Oh,
And
really?
so I
She heads the government
understand
relations
the
up at Cedars.
challenges
Yeah, I haven't
of
been introduced.
the,
Okay, yes.
I'm
and I
relatively
must
new. I've
say
only been here
that there
3
are
years.
Okay, okay. She was at, I went to UCLA, and so she was a relations person.